Hello, everyone. Thanks for joining us today. We're going to be talking today about global perspectives in caring for CML through the COVID-19 pandemic. And today we're very fortunate to have with us Dr. Fabio Santos from the Albert Einstein Hospital in Brazil, giving his perspective internationally from Brazil and how he has treated patients with CML through the COVID pandemic. And my name is Tapan Kadia. I'll be giving a perspective from the US side of how we've been treating patients with CML during the COVID-19 pandemic here in the US at MD Anderson Cancer Center in Houston. And so throughout today's talk, it's going to be sort of a conversation of starting off with the basics of CML treatment and then how we've adapted those basics during the time of the pandemic, whether it be diagnostics, whether we talk about how we're monitoring patients, which tyrosine kinase inhibitors we're using. Are we considering treatment-free responses in patients? How are we dealing with patients who are in advanced phases of disease? And what has changed? What challenges have we been able to sort of meet and then overcome during this pandemic? How we've used new technologies such as telemedicine to be able to monitor our patients over a long distance to reduce the frequency of inpatient visits or hospitalizations and frequent clinic visits, and therefore reduce the risk of COVID exposure. So I'm very glad to be with you today, and I'll start off by talking about the basics of CML. And the audience here, of course, are experts in treating CML, but we just wanted to go over sort of the basics to make sure everyone is level set, and then kind of talk a bit about diagnostics, about monitoring, the definitions of cytogenetic response, of major molecular response, how we're using these in our current practice. And so, as we all know, the CML is driven by the classic translocation of chromosomes 9 and 22, leading to the BCR-ABL fusion gene, known as the BCR translocation or the Philadelphia chromosome. But we know that not only is this diagnostically present in every single diagnosis or subset of chronic myeloid leukemia, but it also drives the disease. And since discovery of the BCR-ABL translocation, and understanding better the biology, scientists and companies have developed small molecule inhibitors of BCR-ABL, starting with imatinib, going into the second generation tyrosine kinase inhibitors, and then more recently third and fourth generation tyrosine kinase inhibitors, which have not only efficiently blocked the disease and led to a very easy to give treatment, but also has reduced the risk of transformation to the more advanced phases, such as accelerated or blast phase. And so the BCL translocation yields multiple different transcripts, as you can see below, the most common being P210 in chronic myeloid leukemia, but also sometimes we see P190, which is often commonly seen in Philadelphia positive acute lymphoblastic leukemia. But just know that the BCR-ABL fusion transcript can come in different shapes due to different breakpoints and introns that can lead to different length, and each of those lengths may suggest different diagnosis or potential prognostic implications. But this is what we're talking about when we talk about P190 and P210, when we're talking about the BCR-ABL translocation. And so first, I thought I'd start out with monitoring the CML course. Obviously, because we have this wonderful biomarker in CML being the 922 translocation, it's very useful to use this as a diagnostic piece, right? So for patients who are diagnosed with a myeloproliferative neoplasm with a high white count and neutrophils and metamyelocytes and left shift and high platelets, if we see a Philadelphia chromosome, then immediately we know that this is chronic myelogenous leukemia. And so that is done by conventional cytogenetics. Obviously, we are assisted greatly by the use of FISH or fluorescent in situ hybridization, where specific probes have been developed to BCR-ABL, and we can pick this up very quickly. Also, it is more sensitive than conventional cytogenetics, able to detect up to 1 in 200 different metaphases. And it's also quicker, right? Conventional cytogenetics, many places, may take 7 to 10 days to get back, whereas FISH can often be turned around within 24 to 48 hours in most institutions, and it is widely available now. So it's a quick diagnostic test. Then we talk about quantitative RT-PCR, or quantitative real-time PCR, which has been standardized around the world to the international scale. And we use qRT-PCR to not only, again, determine the diagnosis in patients who, let's say, don't have karyotype available, but we can also quantitatively monitor the course of treatment. And so since BCR-ABL is not only the biomarker that diagnoses, but also the target of our treatment, we can actually see successively how the BCR-ABL level goes down over time with appropriate treatment with a tyrosine kinase inhibitor. And in fact, we can detect early relapse, we can detect patients who are responding adequately, and guidelines have been developed now by the ELN to determine what is an optimal response or a suboptimal response in patients with newly diagnosed CML. And finally, we have the ability now, and for many years now, to do sequencing, targeted sequencing of the ABL kinase domain in patients who have CML to determine whether there are mutations there. And the importance of this, obviously, is to determine why a patient is resistant to a certain tyrosine kinase inhibitor. So although TKIs such as imatinib have revolutionized the treatment of CML, we know that there are patients who become resistant to imatinib or don't respond well to begin with. And we have further learned that a large proportion of this resistance is mediated by the development of mutations in the ABL kinase domain where these TKIs bind, leading to resistance and leading to better activity with second generation tyrosine kinase inhibitors. And of course, the activity of ponatinib in the sort of the dreaded mutant T315I mutation in the ABL kinase domain. So going on, I think it's important also, we talk a lot about, especially in our studies, such as the large IRIS study and then the subsequent decision studies and the NSND for the second generation tyrosine kinase inhibitor. We talk about things like cytogenetic response and complete or partial cytogenetic response and major molecular response and MR4 and MR4.5. So I think it's important to sort of define these and remind ourselves, at least myself, to understand what these mean, right? So a cytogenetic response obviously is a decline in the percentage of Philadelphia chromosome that we see on routine metaphase cytogenetics. And a minor cytogenetic response is when you drop from 100% or more down to 36 to 90%, as you can see there. A partial cytogenetic response is a bigger response, but not quite a complete response. So again, if you have a residual 1 to 35% of Philadelphia chromosomes pending or remaining after treatment, that's a partial cytogenetic response. Whereas if you have a complete cytogenetic response, you don't see any Philadelphia chromosomes by conventional cytogenetic analysis. And those two, when you look at that as a group, sort of a partial and complete cytogenetic response, that's known as a major cytogenetic response. So just a little bit of terminology, so that when we're looking at these papers and studies, we recognize, aha, okay, so this is what this means. I think these days, with the widespread use of quantitative PCR, fewer and fewer people are using or relying on cytogenetic response as an important category. But certainly, I think one thing to keep in mind as a gold standard to make sure that you are achieving a complete cytogenetic response, at least within the first 6 months to 1 year of treatment with a tyrosine kinase inhibitor. And if you're not achieving that soon, that is a clear alarm bell or signal that there may be a loss or a resistance, either because of non-compliance or because of poor absorbance, or potentially because of the development of some resistance mutations or advanced phase in CML. Then we get into the molecular responses. This is again through the quantitative RT-PCR, which allows us to be quantitative about what we're talking about. So a major molecular response is when you have a 3-log reduction in the BCR-ABL. So when your BCR-ABL by the international scale is down to less than 0.01%, sorry, 0.1%, sorry, see, I messed that up. So major molecular response is less than 0.1%. And MR 4.0 is when you're less than 0.01%. Okay, so that's 1 log further. And then MR 4.5 is basically what we refer to as a deep molecular response, which by the IS is less than 0.0032, or in some institutions like myself or my own, we call them less than 0.01% or barely detectable, which is a very, very deep molecular response, and sometimes can be used as a surrogate for considering treatment-free remission, for example. And then finally, we have complete molecular response where there's no detectable BCR-ABL at all, which is an excellent response. It's probably one of the deepest responses that we eventually try to achieve. So now that we have these definitions in mind, we can then go on to sort of how we monitor CML. And so obviously in the first year gold standard, you want to confirm complete cytogenetic response. Now this is sort of the bare minimum of what you want to achieve. Now with the new molecular guidelines, we actually want to even better that, which is less than 1% BCR-ABL by quantitative RT-PCR. But certainly you need to have complete cytogenetic response within the first year. And on the way, we check a bone marrow or PCR every 3 to 6 months. We used to do more bone marrows more frequently when we were not as keen on using quantitative RT-PCR or not as skilled. But I think more and more we're moving away from bone marrow. I think, especially in my own institution, other academic institutions, it's still important to consider bone marrows, at least early in the course, and potentially at times of late relapse or resistance, to look for things like clonal evolution, to see if you've developed new chromosome abnormalities, to see if you have any interesting chromosome abnormalities at diagnosis, such as monosomy 7 or chromosome 3, that would indicate a more adverse prognosis and a potential for transformation to a more advanced form of CML, such as blast phase. But after that, PCR every 3 to 6 months until you achieve a major molecular response. And then we eventually go to every 6 months and then every 12 months after that. We do a bone marrow at 6 and 12 months to confirm that they are indeed in complete cytogenetic response. And in the next few slides, I'll show you the PCR levels that we want to achieve. Once you're in complete cytogenetic response, as I mentioned, PCR every 3 months to confirm major molecular response. And then if you are in major molecular response, then you can go to every 6 months. Watch for false positive results. Sometimes we have sort of small fluctuations when you're less than 0.1%, and that's often within the error of the test. So you may go from 0.05 to 0.07 or 0.09. Again, it's important to know not to jump on these results too quickly, but to check another one when they're actually less than, when they're within the range of major molecular response, because there can be some small errors that can lead to small fluctuations. But if there's a trend in the molecular PCR rising, obviously that is a concerning sign. You just want to make sure that it's going in the right direction. If the PCR does increase by a log or half a log, what we typically do is increase the frequency of monitoring. Like I said, so instead of maybe every 6 months after they're an MMR, if I see a rising PCR, I might reduce that frequency or increase the frequency rather to every 3 months or sometimes even monthly, to make sure that I'm comfortable that the PCR is actually going down and not continuing to rise in that period of time, which would lead me to look for potential mechanisms of resistance, issues with compliance, or a resistant advanced phase of CML. We do mutation studies if we are suspecting resistance, if we ruled out other things, and if we need to change the tyrosine kinase inhibitor. And we typically change TKI for loss of complete cytogenetic response, which is a major deal, confirmed failure, and also if there are significant toxicities related to the TKI. We have developed now ELN-defined PCR-based milestones, which are much easier to sort of incorporate. These are listed here. And so the time points are typically 3 months, 6 months, 12 months, and then beyond that. And if you look at the log, you want sort of less than 10%, less than 1%, less than 0.1% at each of those time points optimally. Okay, so there's 3 columns here. The first being optimal response, the second being warning or caution, something's not right, and the final one being failure, where like, look, you're bona fide, something's wrong, you need to change or investigate why the BCR-ABL is not hitting the milestones that you want to achieve by that time point. And so if a person is on TKI continuously, optimally by 3 months, you want them ideally less than 10%. But if they're greater than 10%, in the 15-20% range, just keep an eye on them closely. This could signify failure, but it's not a failure. You wait then to the 6-month time point. At that point, ideally, you want them less than 1%, but definitely you want them less than 10% by 6 months. And if they're greater than 10%, I think that's somebody I would be worried about and consider a failure, and maybe check one more PCR in the next month and make sure that you're not at the verge of achieving the milestone, and then look into things like compliance, resistance, et cetera, and then potentially consider changing the TKI. At the 12-month or the 1-year time point, again, remember I said CCYR, which is roughly 1%. So ideally, you want that person to be in major molecular response, which is less than 0.1%. But again, if you're within 0.1 to 1%, you're probably fine. If you're more than 1% at a year, or if you have a persistent cytogenetic abnormality at 1 year, that is considered a failure. And there may be, again, issues with resistance or compliance where you should investigate and make a change. At any time, you want to be in major molecular response or better. And then when you lose MMR, you lose complete cytogenetic response or you lose hematologic response, obviously those are considered uh, markers of failure, and that's where you would consider changing the tyrosine kinase inhibitor or potentially even going to more advanced therapy. So these are sort of the milestones that we want to achieve. I think the biggest thing that people always wonder, and we wonder ourselves, is this number of 10% at 3 months. It's sort of, it's great if you achieve it, but if you haven't, is that really the best time point? And so our practice at MD Anderson is, the real, I think, time point for us is the 6 month 10%. If you're not achieving 10% at 6 months, I think then you have an issue there where you really need to make a change and get serious about what's going on with the patient in terms of compliance. I think the issue with 10%, I think, is the following, where, so if this is your milestone of 10% and that dot represents your PCR, which is just above 10% at 3 months, which is very early on in the treatment, right? A lot of things can happen. So at 3 months, that's really our first major look at the PCR. And so you don't know if the PCR is going down at this slope where there's a really quick drop in the PCR. So even though you're at 10% at 3 months, within a few weeks, you'll be less than 10%. I think and that person is probably going to be fine. Or are you this person where you're at 10% at 3 months, but you're actually having a slow response. So even if you check within a week or 3 months or even 6 months, you're really not going to drop, and you're dropping slowly, and there is some issue with resistance happening that you can't detect. So again, it's hard to determine which is which because you don't have two time points. You don't have a really good idea of a slope of where this is responding. Are these really the same? Probably not. The other question is, are these the same, right? A person who is on a TKI, let's say dasatinib, who has been taking it continuously without stopping, and then is at 10% at 3 months, or a person who's, let's say, having some side effects, some cytopenias or non-compliance, or forgets to take their medicine and has sort of intermittent dosing and is at 10% at 3 months. And so the question is, is one better than the other? Presumably the one who's had continuous perfect treatment and is still above 10% at 3 months, I'd be a little bit more concerned because I'd say, well, look, maybe despite optimal treatment, you're still not responding to hitting the milestone optimally. Whereas the second patient, you have a reason as to why they may not be optimally responding. So those clearly are not the same. And so I think it's important to look at the 6 month time point for that milestone. I think finally, the big question many people have is when to check mutations, right? So we know that mutations in the BCR-ABL gene, particularly the ABL kinase domain and the gatekeeper areas, they confer resistance to tyrosine kinase inhibitors. It's the most common cause of resistance. And we know that different TKIs have differential sensitivities. There have been multiple papers published by this. I think the big one to remember is that a T315I mutation is certainly resistant to most TKIs, but sensitive to ponatinib, which actually is pretty active in most of the other mutational testing. When do you do mutational testing? Well, if you're losing hematologic response, cytogenetic response, and can be considered in patients who have a confirmed loss of major molecular response with steadily rising BCR-ABL levels where you've ruled out all other causes of not responding optimally. So in people who are continuing to respond and doing well, there's no role to do mutational studies. Similarly, in a newly diagnosed patient, there's no role for doing mutational studies, possibly with the exception of those patients who are in advanced phases like blast phase, where you may want to check to make sure that they are not having a T315I mutation. And this is maybe sort of an unrecognized CML that had been going on for months and then transformed at that point. And as I said below, consider ponatinib or omacitaxine or stem cell transplant in patients who have a T315I mutation. When to switch, like I mentioned, if you're beyond 12 months and you've not had a complete cytogenetic response or your PCR is still above 1%, you need to switch based on your mutations and comorbidities. Again, at 6 months, if you had not achieved the less than 10% milestone, I would be very concerned and consider changing the TKI unless I see a further drop in the molecular testing over the next few months. So I would check more frequently. If it's a first generation imatinib, check adherence and switch to a second generation TKI. If your patient is already on a second generation TKI in the front line, check for adherence, check for comorbidities to help you decide what your next TKI is going to be. Look at the mutation profile and switch based on mutations as well as toxicity profile. In some cases, you may be able to sort of reassess, make sure, make sure the patient is adhering to compliance, and then go and change to your next generation TKI at that point. If there is a loss of cytogenetic response, confirm the PCR increased by karyotype, and then don't react to isolated PCR changes. These are those small little changes that you may see after a patient has achieved MMR, where they may fluctuate somewhat, but may not have a definite trend. And many of those may go back into MMR or even better with continued treatment and reminding the patient of adherence and so on. All right, so I'm going to end there, and I'm going to hand off the microphone to Dr. Fabio Santos, who is joining us from Brazil. So thank you, Fabio, for joining us. I'm looking forward to your talk.
Thank you, Dr. Kadia. Thank you for I'd like to thank Total Health for inviting me to come and speak here today. And now I'm going to approach a little bit about CML in the context of the COVID-19 pandemic. If you could just get me the next slide, please. So we're all very well aware of the fact that the COVID-19 pandemic started at the end of December 2019. The first case of pneumonia were diagnosed in Wuhan in China. And unfortunately from there, the COVID-19 virus quickly spread to the rest of the world. And in March 2020, the WHO officially classified COVID-19 as a pandemic. And today, we're recording this on May 2021. We have more than 160 million cases and almost 3.5 million deaths worldwide. And we're racing with vaccination in almost all countries to try to stop this disease. And the COVID-19 pandemic has led to many changes in our society. And one of them being the way that we deliver and medical care to our patients. Next slide, please. So regarding CML and COVID, I'm going to touch on two aspects. Number one, what is the outcome of patients with CML who are being treated with TKIs and who develop the COVID-19 infection? And number two, are there any guideline changes in the way that we should diagnose and manage our patients with CML during these difficult times? Next slide, please. So there are a few papers who evaluate the incidence and the epidemiology of CML and COVID-19. So this first paper is from China, where they audit by questionnaire more than 500 patients with CML in a province in China, and they diagnosed 5 cases of COVID-19. The prevalence was 0.9%, which was ninefold higher than the 0.1% prevalence in the country population that the authors reported. And they could find some risk factors for developing COVID-19 in CML that included exposure to an infected subject, the patient not being in complete hematological response at the time of exposure, patient have comorbidities, and have advanced CML. Next slide, please. So based on that first paper, there was an impression that a diagnosis of CML would increase your chance of developing COVID-19 disease. However, in this other manuscript from Netherlands, they surveyed 148 patients with CML and 123 housemates, and it didn't find an increased prevalence of COVID-19 in the CML patients. They did find that patients with CML had an increased prevalence of some respiratory symptoms such as rhinitis, coughing, and shortness of breath, but only one patient was reported to be tested positive, and that was consistent with the prevalence of 0.7%. Next slide, please. And this other manuscript from Italy, they surveyed 47 CML centers throughout Italy. This was done at the beginning of the pandemic in Italy in March and April last year, when Italy was one of the most afflicted countries at that time. And they only, at the middle of, until the middle of April, there were only 12 cases of CML of COVID-19 among more than 6,000 CML patients. What they did find, what was interesting, was that when surveying the physicians and the centers, they recorded several changes in medical care delivery, like difficulties in working up patient with recent diagnosis of CML or monitoring MRD. They had to postpone MRD analysis for some patients who were in deep molecular response. Some physicians were already starting to propose patients not going for a treatment-free remission trial, since that would entail an increased need for monitoring. In some cases, there were issues with delivering second-generation TKIs to patients' homes, and 1/3 of physicians stopped enrolling patients in clinical trials for CML. And that was, you must remind that was in the beginning of the pandemic. We're still not very adapted to that new way of life. Next slide, please. And that manuscript, I was happy to be one of the authors, a friend of mine from Campinas, a city here in São Paulo countryside. They presented at ASH last year, where they surveyed 24 CML centers here in Brazil. There were 28 COVID-19 cases. Most patients were in chronic phase, and disease was found to be severe in 9 patients, and 54 of severe cases were not in major molecular response at time of the diagnosis of COVID-19. Unfortunately, most patients recovered, and 4 were still in hospital at the time of the report. Next slide, please. And this is the last study that I'm going to present. Was a case collection by the International CML Foundation worldwide, in many centers around the world. Out of more than 12,000 patients, they could find 110 cases of COVID-19 in CML patients, consistent with the prevalence of 0.7%, which is similar to the other studies that are presented. Most cases were mild disease, and I would say 1/3 were moderate or severe. And the fatality rate was 14%, which I would say is a little bit higher than we're used to seeing in COVID-19 overall, but not so much as we would expect from other hematologic malignancies. Next slide, please. So overall, and this is the survival analysis. And we can see they reported that the main driver of survival after a patient was infected with COVID-19 was their age. So elderly patients, they had a worse survival compared to younger patients. They also found a trend for patients being treated with imatinib as having a worse outcome. However, the authors were careful to point out that most patients, there was an association between age and being treated with imatinib. And those results, they are from a univariate analysis. They didn't analyze in a multivariate analysis, so they're not sure that there was strong association between being treated with imatinib and having a worse outcome, so I wouldn't go in that direction. So next slide, please. So now overall, we can see that there were very few papers describing the outcomes of CML patients, and the incidence, they seem to be similar to what we see in the overall population. I don't think they're patients with CML have an increased risk of developing COVID-19 disease. And the main drivers of mortality are the ones that we already know: age, comorbidities, and in some cases, it appears that if you have more advanced CML, you have a risk of having more severe disease. And there are some manuscripts that have been published that speculate that treatment with TKIs may be protective for development of the disease, but there's no solid data to back this affirmation. Next slide, please. So there were some guidelines that were published. There was one from Brazil. I was one of the authors. There's one from MD Anderson Department, also with Dr. Kadia, and there was one that was published from a panel of international experts. All of them cover not specifically CML, but leukemia or MPNs overall. Next slide, please. So all guidelines, when you look at the recommendations, they are pretty much similar. Essentially, what they're gonna tell you, you don't need to have major changes in the way that you diagnose and treat your patients. You need to consider the side effect profile of some TKIs when you are decide to start a patient on a new TKI. You need to consider that some TKIs may lead to cardiovascular issues, diarrhea, thrombosis, and that can be a complication if the patient develop COVID-19 infection. You need to test symptomatic patients. If the patient develop infection, some guidelines such as MD Anderson leukemia recommend that you should withhold TKIs until recovery. Most guidelines do not recommend any change of therapy for patients who have advanced CML, but that's a more severe disease. You need to continue routine PCR testing according to your local guidelines, and try to monitor patients remotely using telemedicine to avoid outpatients visit. And all guidelines say that you should avoid trials of treatment-free remission due to the increased need for monitoring. Next slide, please. And this is from the International Panel of Expert Guidelines. Similar recommendations, no major changes. Start therapy as usual. Use telemedicine to monitor patients. Do not recommend patients go on trials of TKI discontinuation, and treat patients with advanced disease as usual. And next slide, please. The Brazilian guidelines, similar recommendations, use telemedicine, monitor patients remotely. And we recommended to preference for imatinib or low dose dasatinib due to the increased risk of thrombosis associated with COVID-19, but that's just a suggestion. I don't think it's mandatory to go in that direction. Next slide, please. So final mention on vaccination, that all patients with CML should be vaccinated as soon as possible, and no vaccine is contraindicated in a patient with CML. There's no evidence that CML patients have an increased risk of adverse events when they're vaccinated. I need to state this because several physicians and some patients of mine have vaccinated. There's no need to stop or change the TKI therapy if you're going to get vaccinated. And if a patient has a prior history of COVID, you need to follow local guidelines for interval between the diagnosis of COVID and vaccination. For example, here in Brazil, you need to wait at least 4 weeks between having a diagnosis and being vaccinated. Next slide, please. So now I'm going to discuss a case that I had recently at my office, and then I'm going to switch back to Dr. Kadia. This case was a 42-year-old female patient who had a history of non-specific symptoms since January this year. And in March, she started to develop shortness of breath and worsening of her fatigue. She came to an appointment. On a physical examination, she had a palpable splenomegaly, and her CBC showed hyperleukocytosis with left sheath granulopoiesis until promyelocytes and a mildly increased percentage of blasts. Next slide, please. So I suspected of CML, and I decided to admit that patient because she was having dyspnea. And there were 2 things I was considering. Number 1, to accelerate the diagnostic workup and start to cytoreduce her while in hospital. And number 2, there was word that she could have developed COVID. That was in March, where the pandemic here in Brazil was very much worse than it is right now. And unfortunately, her PCR came back as positive. However, her CT scan showed mild lung involvement, less than 25%. So we considered with ID, and at the present, they recommended just to observe and symptom control. We collected her bone marrow aspirate, including cytogenetics and RT-PCR, and we started her on hydroxyurea. Next slide, please. So after 1 week, her PCR results confirmed that she had a diagnosis of P210 CML, and she was started on imatinib and was discharged. And after 1 month of therapy, she came back and she was in complete hematological response. She had fully recovered from COVID disease, and she's tolerating imatinib well, and she's now doing 1 more month for a 3-month return, but so far no major issues with her. So now I'm gonna switch back to Dr. Kadia, who's gonna present his case.
Thank you, Dr. Santos. Appreciate it. I think it's a very nice case. I think I have a very similar case of a patient with the CML and COVID-19. It's interesting. This young lady, very young, 20 years old, she was just going out on her own. She lived in Minnesota, and she decided to leave her home and come to Houston to get a job, and then I think she was about to get engaged to her fiance, so she wanted to start her life away from everyone. The problem was that a few weeks after she got to Houston, she was all alone, and she started developing sore throat, fevers, severe fatigue, malaise. And so you could imagine the parent of this particular young girl, worried sick that now the daughter is far from home, maybe developing COVID. And so she said, look, you need to go to see a doctor. The kid, the 20-year-old said, no, I'm fine. Over the next week or so, she continued to develop worsening cough, dyspnea, shortness of breath. She lost smell. Then she said, wait a second, this is not right. she went to the emergency room, and when she came in, not only did she have a COVID-19 swab positive, but the CBC that was done routinely surprisingly showed a white blood cell count of 151,000. Okay, this was not that she had no other symptoms prior to this. She had COVID, and she was incidentally diagnosed with chronic myelogenous leukemia. And so she was admitted immediately to the hospital, not only because of the hypoxia and cough and fever, but also because of the severe leukocytosis. And you can see the differential there. Neutrophil count 43%, mostly left shift, a few blasts, normal platelet count, and some anemia. And so she was admitted, infectious disease saw her. She was seen by the leukemia service. She was started on oxygen. They started her on remdesivir right away. She did have hypoxia, and steroids were initiated, and she was monitored on the floor. And again, we saw her immediately. Now, because of the differential and the high white count, minimal splenomegaly, we suspected CML. She was otherwise fine. So we immediately started hydroxyurea for cytoreduction. She received 2 hemolysis labs every 8 hours, hydration. We had to be very careful to avoid volume overload. Although she did not have effusions already, she did have bilateral infiltrates in her lungs. And we're certainly worried about adding pulmonary edema or volume overload to the picture to cause worsening hypoxia in a person who's also already requiring 5 to 6 liters of oxygen. And so this was, we obviously, and then the other thing is we were not allowed as much exposure to her as we were our normal patients because she was admitted to the COVID-19 isolation unit. We were able to, because she was in the hospital, we were able to get her bone marrow done very quickly the day after she came in with cytogenetics, FISH, and molecular studies that were rushed to get the diagnosis. The FISH came back very quickly, positive for BCR-ABL as we suspected. And then we went to the multidisciplinary conference with infectious disease, pulmonary doctors, transplanters, and the leukemia doctors to understand how do we best treat this young lady with newly diagnosed CML in chronic phase. And certainly the pulmonary function was our first concern. And was there be a way that we could potentially worsen her function? And then secondary, right around that time, there was a lot of data and a lot of news about high incidence of thrombotic effects, sort of, disfiguring, debilitating thrombotic effects from COVID-19, whether it be strokes, pulmonary emboli, retinal hemorrhages, et cetera, that COVID-19 potentially led to a slightly hypercoagulable state, and these are arterial thrombosis. And so we were very hesitant to use something like nilotinib or ponatinib, for example, because we felt that those had a slightly higher risk of developing these thromboses anyway, and particularly in the setting of an inflammatory state with COVID-19, we were uncomfortable. And so, although dasatinib, we kind of talked about the incidence of pleural effusion and volume overload, she was very young, very healthy otherwise, and so we decided to move forward with the dasatinib, along with the Hydrea, with a very nice drop in her white count, but rather slow. She was in the hospital for another week. We watched her white count drop steadily. TLS was not observed. And then we stopped the hydroxyurea, continued on dasatinib, again with no pulmonary complications. The fever subsided. She was weaned off the oxygen and discharged home. And then we did telemedicine visit weekly because we were minimizing visits to the hospital. She would do the CBC in an outpatient area, get her blood drawn and leave, go home. And then we would review the CBC with her over the phone. On video visits, we'd look at toxicities, et cetera, and everything. We managed that over the web. And then she came back for a 1-month visit in person. We examined her, make sure she was okay, did a CBC, make sure she was compliant. We did a 3-month visit. Our PCR luckily was at 5% at 3 months. Again, if you remember our milestones, that definitely meets criteria. And then after that, we monitored every 3 months via telemedicine visit and a blood draw done outside so that she doesn't have to come to the hospital as often. She's coming up now on her 12-month visit. So she's continues to do well on dasatinib and is free from COVID, is now also has received her vaccinations. And so I think that, just another case highlighting how we treat people with leukemia during COVID. I think, as Dr. Santos pointed out, you don't really change much. You need to treat these life-threatening diseases, but modify what we can do. I think we've learned a lot. Many questions come up, I think, from other physicians, from ourselves. We ask each other. And so these are just some 3 discussion questions I put out there. And it's just for Dr. Santos and I to discuss and see if there's any other thoughts that we can. I think we've covered most of these things. But Fabio, what do you think? Can patients with COVID-19 be started on TKI therapy for CML? What do you recommend mostly to your your colleagues and referring physicians?
Yes, I think for most patients with CML, I would consider starting them on therapy with a TKI, even if they have a diagnosis of COVID, like the patient that presented, the case you presented who had a severe lung involvement. Maybe I had some patients who were diagnosed with CML with very mildly elevated white blood cell count, like the range of 20 to 30K.
Mhm.
Maybe in that patient, if they developed COVID and they were doing well, maybe in that case, if they had a simultaneous diagnosis of CML and COVID-19, and the CML was very mild, maybe in that case, one could consider waiting until they recover. But for most patients, I would start therapy with TKI. Now, the issue would be which TKI would you choose for a patient with COVID-19 infection? That's something of a challenge, I would say.
Yeah, I agree there. I think that's the biggest thing. In the beginning, we were trying to hedge between, do we get the best TKI available? Sure, second, third generation. But then you worry about the side effect profile on these things, right? So, a person with significant lung involvement, do I want to risk getting a pleural effusion? Do I want to risk getting pulmonary hypertension, volume overload, and that would worsen their respiratory status, which is tenuous to begin with? On the other hand, we were seeing thrombosis. We're hearing about life-threatening, disfiguring thromboses with COVID-19 to begin with. Many of our patients started on anticoagulation. So do I go to something like ponatinib? Probably not, or nilotinib, where there is a risk. Or do we do imatinib, which can cause volume overload? I think bosutinib we started using quite frequently because it had many of the few side effects of it didn't really affect the lungs, it didn't really affect the vessels. Certain people had diarrhea, but that was kind of tolerable. But I don't know that there's a preferred TKI. But I think just careful discussion and acknowledging what's going on with the patient is going to be key.
Yeah, I definitely agree. I think in the end, it all comes down to the same way that we manage patients with CML. We're going to consider COVID as one more factor in the equation. We're going to consider other comorbidities that a patient may have, their age. Like you said, ponatinib and nilotinib, if a patient is elderly, has hypertension, diabetes, dyslipidemia, they may have an increased risk of thrombosis, and that multiplies if they develop a COVID-19 infection. We don't have a lot of experience with bosutinib here in Brazil, but I think it would be a good choice overall because its side effect profile is, I would say, more mild compared to what you see with COVID. You don't have, as you mentioned, lung involvement, so that will be one of my choices. And imatinib is also a good choice, I would think. But overall, I think every case needs to be discussed considering all variables of the patients.
Absolutely. I think also let the patient know about the risks and their families, because
Mm.
it's terrifying. Because she was alone the entire time in the hospital. It was terrible. A young lady, she's got COVID, and I said, "Oh, by the way, you have leukemia." So I think the fact that families aren't allowed and we're trying to minimize exposure, it's hard on the patients.
Yes.
Quite frequently. And so far, I think you've covered this really nicely about the role of COVID-19 vaccination in patients with CML. I think that certainly we definitely recommend it. Any other thoughts, words of wisdom in terms of the vaccinations?
I think all patients. I think all patients should be vaccinated as soon as possible. I mean, even to CML, when you get a patient in deep molecular response, he doesn't have. I wouldn't say that he has an increased risk of developing complications, similar to a patient who has like more aggressive disease, like an acute leukemia. But I wouldn't wait to get my vaccination if I had the opportunity to vaccinate. I think this disease is very challenging. COVID is very challenging to control, and I think we're only going to control if as soon as we get the highest number of people vaccinated as soon as possible. So I know that you guys are doing a wonderful job over there in the United States. We here we still need to keep up, but maybe in the next year we're gonna have different sessions discussing CML without the impact of this pandemic in our lives.
Yeah, let's hope for that. Absolutely. I think, yeah, I completely agree and echo your comments about the COVID vaccine. I think that certainly the more people we vaccinate, the more people we protect, the better we get to to get controlling this pandemic. And, you know, I think that most patients with CML should get vaccination. I think there are rare instances where a person is very sick or has a bad disease with CML, where we may delay the COVID-19 vaccination. Some examples may be a person with newly diagnosed disease who, let's say, starts on a TKI such as dasatinib and becomes significantly pancytopenic or neutropenic, which we have seen. And in that person, I may wait till they actually have a response, a complete hematologic response, a better neutrophil count, and then consider delaying the vaccine until that point. But I think other than that, I can't really see many other major contraindications.
No, I agree with you. If the patient has cytopenias, maybe it would be better to wait until they recover to get a vaccine.
Well, great. Well, thank you, Dr. Santos. I think that we've had a really nice chat, and it's good to see you again, even
Good
though
to see you too.
it's been a while. And for the audience, I hope you all enjoyed and found this useful. Thank you for joining us on this first CML webinar. Thank you.
Thank you. Thank you very much. Thank you, Kadia. Hope to see you soon.
Hope to see you soon.